Hello everyone. Today we'll be talking about pancreatic cancer. So in this video we'll discuss the anatomy of the pancreas, some statistics of pancreatic cancer, a brief pathophysiology, common metastatic sites of pancreatic cancer, risk factors, signs and symptoms, diagnosis, treatment, prognosis and references. So when we talk about the anatomy, the pancreas is an oblong-shaped organ that is positioned at the level of the transpyloric plane, which is L1. With the exception of the tail of the pancreas, it is a retroperitoneal organ that's located deep within the upper abdomen in the epigastrium and left hypochondrium regions. So this is the diagram of the pancreas. So when we look at the vasculature, the pancreas is supplied by the pancreatic branches of the splenic artery, which is over here. And the head is additionally supplied by the superior and inferior pancreatico-duodenal arteries. Since the inferior, there is also a superior branch. And these are branches of the gastroduodenal artery, which is from the celiac trunk, and superior mesenteric arteries. The venous drainage of the head of the pancreas is into the superior mesenteric branches of the hepatic portal vein. And the pancreatic veins draining the rest of the pancreas, they do so via the splenic veins. So, statistics: pancreatic cancer is the 10th most common cancer in men and the 8th most common in women, but it's the fourth leading cause of cancer deaths. It accounts for about 3% of all cancers in the US, but is responsible for about 7% of all cancer related deaths. Both the incidence and the death rates for pancreatic cancer are increasing. And what is important about pancreatic cancer is in 80% of the cases present at an unresectable or incurable stage. So they do not present early. So pathophysiology is pancreatic cancers. They can arise from the exocrine or endocrine portions of the pancreas, but the vast majority develop in the exocrine portion. So that includes the ductal epithelium, acinous cells, connective tissue, and lymphatic tissue. And another thing of note is of all pancreatic malignancies, 90% are adenocarcinomas of the ductal epithelium. Then common metastatic sites. So typically pancreatic cancer first metastasizes to regional lymph nodes, then to the liver, and less commonly to the lungs. It can also directly invade surrounding visceral organs such as the duodenum, stomach, and colon, or it can metastasize to any surface in the abdominal cavity via peritoneal spread. And pancreatic cancer, it rarely spreads to the brain, but it can produce meningeal carcinomatosis. I go to the risk factors. Tobacco smoking. So this is the most common recognized risk factor for pancreatic cancer. Then other factors include obesity, diabetes mellitus, chronic pancreatitis, family history of pancreatic cancer, hereditary syndromes, lifestyle factors. And less than 5% of all pancreatic cancers are related to underlying chronic pancreatitis. Alcohol consumption, it does not appear to be an independent risk factor for pancreatic cancer unless it is associated with chronic pancreatitis. Then signs and symptoms include the initial manifestations of pancreatic cancer, they are often non-specific and consequently they are often misinterpreted. However, patients with pancreatic cancer may present with the following signs and symptoms. So that is significant weight loss, then mid-epigastric pain. This is a common symptom of pancreatic cancer, and sometimes it may present with radiation of the pain to the mid-back or lower back region. Then nighttime pain, so it's often a predominant complaint that is the pain is increased at night. Then onset of diabetes mellitus within the previous 2 years. Painless obstructive jaundice, pruritus, which refers to itching, migratory thrombophlebitis, which is the trochlear sign, and deep venous thrombosis. Then there may be a palpable gallbladder, which is the Courvoisier's sign. Then presence of ascites, a palpable abdominal mass. Hepatomegaly, that is from liver metastasis or splenomegaly due to portal vein obstruction. Then paraumbilical subcutaneous metastasis, which we also refer to as testimony Joseph nodule. So diagnosis, as we said, that 80% of cases present at an unresectable stage. So that is because it is difficult to diagnose. Lab findings are non-specific, so you can do a complete blood count, liver function test, liver enzymes, serum amylase, serum lipase, and tumor markers such as CA19-9 occurs in embryonic antigen CEA. So when you talk about the lab findings, so you may see elevated liver transaminases, bilirubin, and alkaline phosphatase levels on testing that is performed for other purposes. Then, due to malnutrition, they may have low serum albumin or cholesterol level. Then, patients that present with obstructive jaundice, they may present with elevations in bilirubin, ALP, gamma glutamyl transferase, and rarely AST and ALT. Then, serum amylase or lipase levels, they're elevated in less than 50% of patients with resectable pancreatic cancer and in only 25% of patients with unresectable tumors. Then, tumor markers. So 75 to 85% of patients have elevated CA19-9 levels and 40 to 45% have elevated CEA levels. The under imaging studies, so this aid in the diagnosis of pancreatic cancer. They include CT scanning, transcutaneous ultrasonography, endoscopic ultrasonography, magnetic resonance imaging of the abdomen, so it is MRI of the abdomen, then endoscopic retrograde cholangiopancreatography, which is ARCP, and positron emission tomography scanning, which is the PET scan. So, management surgery is the only potentially curative treatment modality for early stage pancreatic cancer. However, surgery is increasingly incorporated in a multimodality approach that includes neoadjuvant and adjuvant chemotherapy and or radiation therapy. So, under surgical options, so potentially curative resection options, they include pancreatic or duodenectomy, which is also known as the Whipple procedure. This may be done with or without sparing of the pylorus. Then there's total pancreatectomy, there's distal pancreatectomy. Then under chemotherapy, so we report folfirinos, which is folinic acid, leucovorin, 5-fluorouracil, 5-FU, irinotecan, oxaliplatin. So this is the neoadjuvant and adjuvant therapy, and it's the first line therapy in metastatic disease. Then supportive therapy. So this is used in conjunction with active anti-cancer therapy or as a primary modality in patients approaching the end of life. So you administer pain relief, which is non-opioid and opioid analgesics. Then you can do celiac plexus lysis that's performed endoscopically under CT guidance. Then there's endoscopic interventions for biliary or duodenal obstruction, secondary to pancreatic carcinoma, dietary and nutritional support, management of pancreatic insufficiency. Then behavioral support that is focusing on coping mechanisms, anxiety and depression for both the patients and their families. So prognosis. So unfortunately, pancreatic carcinoma is usually a fatal disease. Then the relative 1 year survival rate for patients with pancreatic cancer is only 28%, and the overall 5 year survival rate is 9%. So these were my references, which is Medscape and Teach Me Anatomy. So that's all about pancreatic cancer. If you like the video, please like, subscribe, and comment. Thank you.